right iliac fossa and imaging modality and imaging approach to diagnosis. From our MBBS days, we have been always exposed to abdomen as a Pandora box. So abdominal pain has several differentials. Like I'll be targeting mainly on the right iliac fossa as considering abdomen as Pandora box. We have compartmentalized, like our super seniors have always compartmentalized into 9 compartments. So the topic that I have chosen is the right iliac fossa, as it is the commonest thing which we come across in our day-to-day OPD practice, as well as it's a important exam-related question. In PJ Mehta, which is the clinical medicine book, we always have been exposed to that first page, saying that the eyes cannot see what the mind doesn't know. So that is the reason I'm exposing you to the right iliac fossa, that the eyes can see what the mind will probably know now. So going to the contents of right iliac fossa, we have the appendix, the ileocecal region, the terminal ileum, the kidneys, that is the retroperitoneum, the lymphatics, and the vessels. However, I won't be covering the renal part of it, and will just target on the bowel and the appendix. So going to the diagnostic laparoscopy in right iliac fossa, according to the international journal, the Surgical Review International Journal, they have also always targeted right iliac fossa pain as acute appendicitis, appendicular abscess, and appendicular lump. But we need to know that this will comprise only of 60% of pathologies. Rest 40% we cannot neglect. And that is the reason that we need to also pay attention to the things other than appendix. So now going to the ACR appropriateness criteria, it has been divided according to right lower quadrant pain, suspected appendicitis again. But here also appendicitis is in adults. It's in adults. Then you have the pregnant women and children which is less than 14 years of age. So in a nutshell, the ACR appropriateness criteria in pediatric, the modality of choice is ultrasound followed by CT. In adults, it is CT followed by ultrasound. And in pregnant females, it is ultrasound followed by CT again. Followed by MRI again. CT does not have a role in pregnant females because of the ionizing radiation. So moving towards the classification of RIF pathologies, we would prefer classifying it on age, the criteria of age, and organ of involvement. However, whichever way you classify it, one thing which we always have to remember is IIM, that is infection, inflammation, and malignancy. This holds true anywhere in the body as well as the right iliac fossa. So going to the age-dependent criteria, I have classified it into pediatric age group, adult, male and female, and elderly. So in children, we will be seeing cases of intussusception, appendicitis. In adults, we will go through lymphoma, inflammatory bowel disease, epiploic appendicitis. In adult female, we will be going through ruptured ectopic pregnancy, adnexal torsion, and in elderly, we will go through cecal tumor and cecal volvulus. Though there are 28 pathologies according to the chart of pain, because right lower quadrant pain, but I have just targeted these because these are the ones which we see in our day-to-day practice, as well as in our exam papers also, we will be finding questions on them. So now proceeding to imaging features and various conditions. In children, as I said, we will target on intussusception. So intussusception is nothing but bowel and bowel appearance. We see more so in children and less so in adults. So in children, we'll have 90% times intussusception. Patient may present to your emergency department saying that there is a lump and a pain in right iliac fossa with current jelly stools. This is the typical presentation in less than 2 years of age. So in children, 90% times it is idiopathic. And few times we also get lymphoid hyperplasia. So the lead point of the intussusception, which is giving rise to bowel and bowel appearance, or one bowel entering the other bowel, is a lymph node, which is usually seen post-viral infection, common in kids. And in less than 10%, the cause might be Meckel's diverticulum, on which I will have a slide subsequently. However, in adults also, we do get intussusception, and here it is the reverse order as compared to children. In adults, 90% it is a demonstrable cause. So here 60% will be neoplasms, which might be malignant or benign, and 30% it might be non-neoplastic, such as inflammation or trauma, and in only 10% it will be etiopathic. However, the pathognomic signs of intussusception will always be a target sign, which will be a peripheral hypoechoic ring, and a central echogenicity will be the pseudokidney sign. Moving towards intussusception. Now, from where does intussusception come? It has two components, intussusceptum and intussuscipium. So, intussusceptum is the telescoping segment of bowel, whereas intussuscipium, that is the recipient, is the distal segment which is receiving this telescoping segment. This is a CT image, the axial CT image, which is showing a telescoping segment of bowel, that is the susceptum, which is significantly edematous with fat stranding, with the receiving segment, which is the intussuscipium. This is a coronal reformatted image of another patient, which is showing significant fat stranding, mucosal edema. And you can see this intussusception. Now, intussusception is one of the entities in which the radiologist will not be only at the diagnosing end, but we also have a role in treating it. We treat usually the intussusceptions in pediatric age group, less than 2 years of age, preferably. So there are modalities like in our age-old days, we used to have a barium fluoroscopic reduction, which then proceeded to the pneumatic reduction. This was again fluoroscopy guided, but now we have advanced to the hydrostatic ultrasound guided reduction. So in here, you can see this video playing where we have the intussusception. Here you can see the fluid entering the bowel and giving rise to reduction of the intussusception. So now you have to consider when it comes to hydrostatic ultrasound guided reduction of intussusception, there is a rule of 3. You have 3 attempts, 3 minutes duration, and the liquid enema bag, the normal saline or ringer lactate at a height of 3 feet from the tabletop. As well, before we go ahead with the rule of 3 or intussusception reduction hydrostatic, we have to consider that the bowel, there is vascularity in the bowel and there is no necrosis, as well as there is not too much of ascites, because these two are absolute contraindications for hydrostatic ultrasound guided intussusception reduction. Now, as I told you, I'll be going to Meckel's diverticulum also. So in less than 10%, the cause of intussusception in children might be Meckel's diverticulum. So here we have a slide. This is an laparoscopic intussusception was planned, the surgical part. This is the intussusception. And when it was reduced, you could see this tiny outpouching, which is a Meckel's diverticulum. This is along the anti-mesenteric border. This is the intra-op image of a laparoscopic intussusception correction. So what is Meckel's diverticulum? It is a congenital anomaly of the GI tract, non-obliteration of the omphalomesenteric duct. So it is along the anti-mesenteric border, as we can see it here. It is approximately 100 centimeter from the IC valve. The reason we need to know about Meckel's diverticulum, because it may just present as a pain in right iliac fossa, giving rise to inflammation, giving rise to pain in the right iliac fossa. It may present as perforation. It may present as intussusception, or it may just present as bleeding from the ectopic gastric mucosa. So here we have an ultrasound image which is showing an inflamed Meckel's diverticulum with trace of fluid giving rise to peritonitis. So this patient must have presented with inflammation, pain in the right iliac fossa secondary to inflammation. So you need to remember the golden rule, that is the rule of 2, which is used in Meckel's diverticulum. The rule of 2 comprises of, it will usually affect less than 2 years of age. It is 2 times more common in a male child. It will affect 2% of population. As I said, the border is approximately 100 centimeter from the IC valve. So that is 2 feet proximal to the IC valve. It is 2 inches in length, and 2% adults also may manifest symptoms. As well, it has 2 ectopic tissues. Since it is omphalomesenteric duct derivative, it may have gastric and pancreatic mucosa. As well, gastric mucosa, you may have a bleeding from the ectopic gastric mucosa. That might be the mere presentation of Meckel's. So here we have a CT image which is showing an inflamed Meckel's diverticulum. Here you have the diverticulum entering the antemesenteric border of the distal ileum. Going back to our classification, which is age dependent, now we go to appendicitis, which is one of the commonest, rather the ACR appropriateness criteria. Even the Laparoscopic Surgical International Journal also calls right lower quadrant as appendicitis. So the diagnostic accuracy of ultrasound will be, it is highly specific and sensitive, with 40 to 90% of it being sensitive and specific. As well, CT is the modality of choice when in ultrasound is inconclusive or in an obese individual. So going to imaging in appendicitis, the most important thing which we need to remember is graded compression with a high frequency linear probe. In day-to-day practice, what we usually use in pediatric or in thin individual is a 12.5 megahertz linear transducer. Whereas in like in slightly obese or difficult patients, we can use a 9.3 linear transducer. What we'll find on ultrasound will be a non-peristaltic, non-compressible tubular structure. The AP dimension of this has to be taken from the outer to outer diameter. Ultrasound criteria, the AP dimension more than 6 millimeter, you can call it acute appendicitis, whereas in CT it is 7 millimeter. At times you may find an obstructing calculus, like here you can see a hyperechoic appendical lith with a posterior caustic shadowing. This is the cause of the inflamed appendix because it is obstructing the pathway. You have a CT image which is showing an appendicolith with significant fat stranding and an inflamed appendix. Similar, you can see significant fat stranding with an inflamed long appendix. Now, what you have to look for, it is not just what acute appendicitis what we are looking at, because acute appendicitis, we can still have a wait time. But when you don't see an inflamed appendix, but you see a significant wall stratification, in this ultrasound image, you can see a significant wall stratification. The total morphology of appendix is lost. So here, this is a gangrenous appendix. This is of importance because it is an emergency and this may lead into complications as we see on CT. Here you can see an inflamed appendix with significant fat stranding with the complication of localized abscess formation. This might be secondary to the perforation, sealed off perforation resulting into local abscess formation. MRI. MRI has a role in appendix only in pregnancy. Here we just run a plain multiplanar HL-T2 weighted images. This is a plain study. We don't give a contrast. The importance of MRI is that it will also help in finding out the normal appendix as well as the inflamed appendix. Here you can see an inflamed appendix with significant periappendiceal inflammation. Going back to our table, so now we go to the inflammatory bowel disease and epiploic appendicitis, proceeding to the adult right iliac fossa pain. So inflammatory bowel disease has been just covered. So I will just brush through Crohn's and ulcerative colitis. Rather, we'll target only at Crohn's because Crohn's is the disease which affects the terminal ileum more so. So the small bowel is 70 to 80% involvement with skip lesions, with a fat halo sign in small bowel and aphthous ulcers. Here we have barium. This is a double contrast barium enema, which is not these days used because with the advent of MR enterography and CT scan contrast enhanced, we don't use barium. but this is just a point to remember. You can see collar button ulcers when it comes to ulcerative colitis, whereas you see aphthous ulcers when it comes to Crohn's. So this is a double contrast enema, which is showing a filling defect with central filling, that is the aphthous ulcer. And this is a complication of Crohn's disease, which is showing complete destruction of the cecum with a fistulous connection between the destroyed cecum and the urinary bladder. So proceeding to the CT, the contrast enhanced CT, this is the classical, that is the comb sign. Comb, because it has a comb-like appearance, it is secondary to engorgement of the vasa recta that penetrate the bowel. This comb sign very well correlates with the extensiveness of Crohn's disease, how active Crohn's is. However, the pathognomic sign of Crohn's will be the creeping fat sign. Here you can see, this is the eggshell image of another patient, which is showing a small area of involvement of the by the Crohn's, that is the terminal ileum. You can see fibrofatty proliferation along the mesenteric border of the affected bowel. Though this will not tell you the extensiveness of Crohn's, but it is pathognomic for Crohn's disease. This is the intra-op image where you can see the creeping fat sign. This is another example, another patient with Crohn's, where you can see significant mucosal hyperenhancement and a narrow constriction, which was just covered in a previous talk. This is a complication of Crohn's. Here you can see a Y-shaped fistula with thickened terminal ileum, with the connection, the fistulous connection with the cecum, and a sequelae, that is a focal abscess formation in the right psoas muscle. Going to the next, that is the epiploic appendigitis. Epiploic appendigitis, basically these are the peritoneal pouches which are arising from the serosal surface of the colon. So epiploic appendigitis, it is usually seen in middle-aged patients, but it is a self-limiting condition. It happens usually because of the torsion and the venous thrombosis of the epiploic appendages. So typically, it will usually present with as a left lower quadrant pain, but rarely it may mimic appendicitis. That is the reason that we need to know this term. CT is diagnostic of this condition, where you can see fat attenuation with a hyperattenuating rim. Here you have an eggshell image in which you can see significant fat stranding. Moving to the next is the adult female. This patient will typically present in a age group of reproductive age group, will have a beta HCG positive. However, you need to know that you have to do an endovaginal ultrasound and see whether there is an endometrial sac, intrauterine gestational sac. In the absence of intrauterine gestational sac, please see the adnexa. In the adnexa, many a times you may find an irregular sac-like structure with an embryonic pole. You may or may not see a cardiac activity, and you may have some fluid in the pouch of Douglas. Here you can see the right ovary is separate. There is fluid in the pouch of Douglas. This is a ruptured ectopic, and it is a surgical emergency, as the patient may go into a hypovolemic shock. The second in line, we have the adnexal torsion. So the adnexal torsion, it might be complete or it might be partial rotation of the adnexa along the vascular pedicle. It might be ipsilateral, usually ipsilateral. You have two things. You need to remember, it might be an incomplete torsion, it might be a complete torsion. So here you have an ultrasound image which is showing a mass lesion in the right adnexa. On endovaginal ultrasound, you may see a edematous ovary with multiple peripheral fluid-filled spaces. These are basically the tiny follicles. The ovarian volume usually does not go beyond 10 to 20 maximum, even in a case of polycystic ovarian disease. However, here you can see this patient had a volume of around 80 to 100 cc. Here we need to understand that it might be an incomplete torsion or a complete torsion. In an incomplete torsion, on a Doppler image, you may get some vascularity. However, on a complete torsion, there will be total loss of vascularity on Doppler. As well, you may get a hemoperitoneum. Here you can see in the pouch of Douglas, there is echos with the edematous right ovary, and this is the uterus with the endometrial cavity noted. So this was a right ovarian torsion with a hemoperitoneum. Ovary always gives us time because of its dual blood supply, one from the uterine artery and other is from the ovarian, which is the direct branch of aorta. And that is the reason that ovarian torsion, if well reported in time, can save the ovary. Proceeding to the next, that is the cecal volvulus. This is usually seen in the elderly age group, though it is a rare condition, but in clinical practice, it may not be that rare. It presents in elderly age group with an abnormally mobile cecum. The predisposing factors may be lacritomy, distal obstruction, and the patient may present to you with an acute, constant cramping right lower quadrant pain. There are 3 types of cecal volvulus, which we need to know. It totally depends upon the mechanism of volvulus, of torsion. You have type 1, that is the axial torsion. Here, this is a cecum, which will twist along its long axis. Then you have the type 2, that is the loop type. Here, the distended cecum will twist and invert also. You have the type 3, that is the cecal bascule. That is the distended cecum over here will fold anteriorly without any torsion. So going to the imaging of cecal volvulus, the diagnosis on plain radiography is less than 50%. With the advent of CT scan, none of us do a X-ray. However, the X-ray of cecal volvulus is very difficult to differentiate from a sigmoid volvulus. Over here, you can see a air-filled bowel loop, which is right in the midline. So the diagnostic is CT scan. Here we can see a dilated cecum, which is twisted along its long axis. And here we can see the swirl sign of the vessels, that is the whirlpool. The vessels are getting twisted. Proceeding to next is the cecal tumor. Now, malignancies in the right lower quadrant may present as pain in the right iliac fossa. At times, the clinical presentation may be anorexia. It may have some occult blood in stools, or it may present as an acute abdomen with a perforation. Adenocarcinoma, 95% of all malignant cecal masses will present as adenocarcinoma. It may show as focal concentric mass with an overhanging shoulder. It may be associated with pericolic nodes. The next in line is a lymphoma. 80% of lymphoma of ileum and colon occur in the ileocecal region. The reason again being Peyer's patches, lymphoid tissue, which will hypertrophy, which will undergo malignant change. Lymphoma is usually seen in 50 to 70 years of age group, whereas adenocarcinoma is seen in a slightly younger age group. Normally in adenocarcinoma, you may get perilesional fat stranding, which is less likely in cases of lymphoma. As well, in lymphoma, you need to remember that there are 5 forms of lymphoma which will occur in the ileocecal region. You have the most common, it is the most common mimic of adenocarcinoma. You may have a concentric constrictive pattern. You may have a polypoidal or a nodular pattern, as we see in this case over here. You may have an ulcerative pattern. You may have an aneurysmal dilatation and exophytic pattern. Over here, you have a classical lymphoma, which is showing lack of bowel obstruction. This is a long segment, which is showing a gradual transition from normal to abnormal thickening, which is eccentric. As well, we need to remember, see, this is the aneurysmal dilatation, where you can see a bowel wall thickening with air and contrast medium, which has been entrapped in between. So this is an aneurysmal dilatation. This is the aneurysmal pattern of lymphoma. So now going to the selection of the most appropriate imaging modality when it comes to right iliac fossa pain. As I said, it depends upon the patient's age as well as body habitus. In less than 20 years of age, ultrasound we should consider regardless of the suspected pathology, followed by CT scan. However, in a reproductive age group, ultrasound followed by MRI, and in old and obese patients, we can opt for CT. So the checklist you should always remember before you start with scanning of the patient, check with the age, the gender, the clinical findings. Then go through the list of incidents. Just don't look at the 60% incidence, but also think about the 40% incidence. So, as I said, age dependent, organ of involvement, and the golden rule, infection, inflammation, and malignancy, IIM. To summarize, in pediatric age group, think about intussusception, less than 2 years of age, current jelly stools. Then think about appendicitis. In adults, think about appendicitis, inflammatory bowel disease, epiploic appendicitis. In adult female, in a reproductive age group, ruptured ectopic, adnexal torsion. In elderly, think about cecal tumor, cecal volvulus, as well as adenocarcinoma, lymphoma. So going to the advantages of ultrasound, it is a non-invasive, rapid modality and inexpensive with no ionizing radiation. However, it is operator dependent and it is challenging in overweight adults. It will allow us as radiologists to confidently exclude appendicitis, think about things other than appendicitis, the surrounding organs, as well as will help us know the severity and the extent of disease. However, disadvantage its ionizing radiation as well as contrast enhanced CT is not always possible. So though the king of right iliac fossa is appendix, but the other support group members also need to be thought of. It will not always be appendix. So always remember IIM, infection, inflammation, malignancy. This is true not only in the right iliac fossa, but anywhere in the body. It starts most of the times with some infection and inflammation, and when it reaches chronicity, it may go into malignancy. So my conclusion would be, in patients with acute abdomen, the stakes are high. A misdiagnosis may have a serious consequence. Every right iliac fossa pain is not appendicitis. We need to think about the Pandora box. We need to think of out-of-the-box imaging. Rare things, though rare, we need to sort them out. First, always focus on the most common disease. Don't think about what you have read recently, some unusual case. Though, you have to exclude the common diseases first. And always screen the whole abdomen. Though we have an anatomical distribution and compartmentalization of the Pandora box, but a right iliac fossa pain might be just a radiating pain from the gallstone, from cholecystitis. That's why screening of the whole abdomen is a must. Thank you.
Thank you, ma'am, for this wonderful talk and simplifying things for us in this wonderful systematic way. I think